All right, today we're going to be talking about optic perineuritis. And optic perineuritis means that it's around the optic nerve. So if this is the optic nerve, the peri, like perimeter, is the sheath. So it's perineuritis when it involves the optic nerve sheath. And so in axial on the MRI scan, we get this tram tracking sign because the sheath it's enhancing. And on the coronal, on the MRI, we get like a target where the enhancement is in the sheath. So clinically what this looks like is it's any age patient, although they're often younger. They have acute onset of loss of vision in the affected eye. It can be unilateral or bilateral. And often the pain is out of proportion to the finding. It's not like demyelinating optic neuritis where they have pain with eye movement. It's normally pain with eye movement, but severe pain. And so any age, acute onset, unilateral or bilateral, optic neuropathy with a RAPD if it's bilateral, and often the optic disc is swollen, but it can be normal. So when we have disc edema, acute onset, pain, imaging study is showing perineuritis rather than parenchymal enhancement, that's when you should really be thinking about optic perineuritis. And we see optic perineuritis, some conditions like to involve the parenchyma, like demyelinating optic neuritis, and some like to be in the sheath. So the things that like to be in the sheath are granulomatous disease, but especially sarcoidosis, but any kind of granuloma can go into the sheath like this. IgG4, but any kind of orbital inflammatory pseudotumor can involve the sheath and look radiographically and clinically like optic perineuritis. And MOG. So MOG is the new kid on the block in terms of enhancement of the sheath. Often it's like shaggy enhancement going out into the fat, and they have disc edema and severe pain, but no demyelinating white matter lesions on the MRI. If you do the whole workup and it's negative, we normally just treat with steroids empirically, and if we don't find anything, we're going to call it idiopathic optic perineuritis. But you should work it up for the usual suspects: syphilis, sarcoid, tuberculosis. It could always be lymphoma. And so if it doesn't get better with steroids or recurs during the taper, we might still have to do a diagnostic biopsy. But most of the time we just treat empirically and test for the labs. For sarcoidosis, we're going to do a chest x-ray and an ACE, but sometimes CT of the chest is necessary. So in summary, optic perineuritis looks different than optic neuritis. It usually is young people, but it can be any age. It presents with an acute unilateral optic neuropathy. The pain is usually disproportionately greater than the demyelinating optic neuritis, which just produces pain with eye movement. It can be unilateral or bilateral. They're going to have an RAPD, and they might have optic disc edema. You should be thinking about sarcoid, IgG4, MOG. If the workup is negative, treat with steroids, and if nothing comes up and it doesn't recur, it's idiopathic. If it recurs or persists, you might have to biopsy it because other infiltrative things, including infiltrative neoplasm like lymphoma, can go right into the sheath.